On November 1st, 2024, the Centers for Medicare and Medicaid Services, that is CMS, released right on time the final rule for 2025 for the Medicare Shared Savings Program, that is the MSSP, and the Quality Payment Program, that is the QPP. In this episode of Ask Dr. Mingle will do a high-level review of the pertinent changes as they relate to the Medicare Shared Savings Program, alternative payment models, the Merit-Based Incentive Payment System, that is MIPS, and MIPS value pathways, that is MVPs. In coming days and weeks, we'll be joined by individual subject matter experts from our Mingle Health team as we take a deeper dive into topics they feel are of importance, and we take any questions you submit seeking more clarity or a deeper understanding about the 2025 final rule. So, Dr. Mingle, take it away.
Thank you, Kyle, and thanks to all of you tuning in. As you may be aware by now, rules for these programs change significantly every year. There's an annual predictable rhythm to the rulemaking process. Before rulemaking, there's legislation. Congress proposes a legislation. Once it passes both houses and is signed into law by the president, it goes to the appropriate federal agency for administration. Legislation sets the overall agenda, objective, and boundaries. It's up to the administrative department to translate the legislative intent into specific rules by which to operate the program. Because the QPP and MSSP, that is the Quality Payment Program and Medicare Shared Savings Program, relate to Medicare's payment for healthcare services, they are in the habit annually of updating the rules for these programs in the same set of documents they use to update the physician fee schedule and other healthcare payment-related rules. Typically, it's as reliable as clockwork. There are exceptions. There are some urgent and emergent circumstances that can warrant either proposing the finalizing some rules in other rulemaking processes, abbreviating the rulemaking process, or even skipping it altogether in certain emergent situations. In general, though, it's pretty reliable. A proposed rule for the physician fee schedule, the Quality Payment Program, and Medicare Shared Savings Program is released on or about the 1st of July. We're given 2 months to read it and submit comments. Medicare gets 2 months to read the comments, adjust and finalize the rules. Then the final rule is released on or about the 1st of November. Most of the rules go into effect January 1st. Some are immediate, some are retroactive in a sense, some are put in place to start in a future year. So that's background. Let me dive into this, the final rule for next year's programs. Now, some of the most anticipated and consequential rules relate to the Medicare Shared Savings Program. Now, if you're not in the Medicare Shared Savings Program, you don't anticipate to be there anytime soon, you can skip this section and go on to my other sections. I've divided this discussion into the Medicare Shared Savings Program, alternative payment models, MIPS, that is the Merit-Based Incentive Payment System, and MIPS value pathways, that is MVPs. So first, back to the MSSP. Let's talk about quality measurement. MSSP ACOs are required to measure the quality of their care, submit quality measurements to Medicare, and meet minimum quality standards in order to qualify to collect a share of healthcare savings they may have generated. Now, this final rule confirms what we've anticipated for several years now, that the web interface mechanism of measuring and submitting quality will end after 2024 measurements are completed in submission. This is not so much a measurement as a sampling technique predominantly done with manual chart abstractions. It's been the predominant method of quality measurement by ACOs since 2013, when ACOs were introduced by Medicare as a health care delivery and payment method. When the web interface sunsets after 2024 measurements and submissions, ACOs will have to use one of three mechanisms to measure and submit quality of care data. One option is the electronic clinical quality measures, that's ECQM's mechanism. Another is the new Medicare clinical quality measures mechanism, or for 2 more years, that is 2025 and 2026, the MIPS CQM's clinical quality measures mechanism. Yes, MIPS clinical quality measures, that is MIPS CQMs, are preserved for ACO use for 2 more years. Now, as for Medicare CQMs, They have performance period benchmarks for the first year in 2024, but this rule finalized flat benchmarks for the 2025 for the core APP set of measures using Medicare CQMs. Flat benchmarks for the first 2 years as each new measure is introduced into the APP Plus measure set. Now, this rule finalizes a new set of measures applicable to the MSSP and to other APMs. Based on the APM performance pathway, that is the APP, Medicare just finalized a new APP Plus measure set, which includes additional measures that will phase in over the next few years. For 2025, in addition to hemoglobin A1C, depression screening, and blood pressure control, APP Plus is requiring the breast cancer screening measure that we've been familiar with from years past. Same measure, no longer available for use in MIPS, in traditional MIPS, but available here for use for MSSP ACOs and other APMs. Now, for 2026, APP Plus will include colon cancer screening. For 2027, treatment of substance use disorder, that they call it initiation and engagement. For 2028, the last two measures, screening for social drivers of health and adult immunization, will click in. Now, those last three measures, substance use disorder, social drivers of health, and adult immunization, are not currently supported by ECQM specifications, and Medicare intends to postpone those if the specifications are not yet ready and published. The APP Plus measure set aligns MSSP quality measurement with 10 adult universal foundation measures that is also the basis for Medicaid core sets, for marketplace quality rating system, for value in primary care MVP, and also is converging with Medicare Advantage quality measurement and Part D star rating. Expect all of these measure sets from now on to remain coordinated through what Medicare is calling that universal foundation measures. They've put an infrastructure in place to support that universal foundation measure set. There's a set for adults, a set for children. Of course, for these programs, for this the MSSP program and other APMs in Medicare, it's only using the adult measure sets. Now, the original APP measure set is still available for use by MIPS APM entities other than the MSSP. MIPS APM entities can also choose to submit the APP Plus measure set. MSSP organizations must use the APP Plus measure set. It is intended from now on to be the standard for MSSPs to qualify to collect their shared savings. Now, neither the APP nor APP Plus is available to any traditional MIPS providers or practices. Now, moving on, there is a new complex organization adjustment. It's to incentivize ECQM submission. It applies to complex organizations like HCOs and APM entities, and it also applies to virtual groups submitting traditional MIPS. The bonus is one achievement point for each ECQM submitted by one of these organizations. It must meet case minimums and data completeness criteria. It's capped. You can't go above 10 measure achievement points for each measure. So if you get a perfect score for a measure, you can't also collect that complex organization adjustment. And of course, you're capped at 100% for the quality category. Notice it applies not only to the ACO and other APMs, but also to virtual groups and traditional MIPS. Now, there's also an alternative quality standard we've seen in the last few years when the APP measures were submittable by web interface or by ECQMs, MIPS CQMs, or for this 2024 year, Medicare CQMs. Those who used the APP CQM measures early were given an alternative quality standard. Usually, the current standard is that your composite score on quality needs to be at the 40th percentile or above. But for users of ECQMs or MIPS CQMs, they were given an alternative standard that means that one outcome measure has to be at least at the 10th percentile, and one other measure, could be an outcomes, could be any of the measures, has to be at or above the 40th percentile. So it's a lot easier to hit, and as measures become more numerous in APP Plus, it's even a bigger advantage to use one of these methods. Now it applies to anyone. They've extended it now as long as it would appear, as long as Medicare, as long as Medicare CQMs are permissible, anyone who uses an all patient, all payer method like ECQMs or MIPS CQMs will get the alternative quality standard. So again, a lot easier to collect your shared savings. Now, we've seen a health equity benchmark adjustment introduced in the past. Its design was tested and refined in the REACH program. It's now being used as a third method to upwardly adjust historical benchmarks for MSSP ACOs and applies to agreement periods beginning on or after January 1st, 2024. So if you're a new or renewing ACO anytime after January 1, 2024, the health equity benchmark will apply to your historical benchmarks. Now, promoting interoperability is an interesting topic for MSSPs. Now, there's no new rules pertaining to MSSPs and promoting interoperability in the 2025 final rule, but one of the most consequential rule changes for MSSPs was finalized in the 2024 final rule, but scheduled to take effect for 2025, starting January 1st, 2025. So starting then, all participants in MSSP ACOs, and indeed any alternative payment model, is now required to use CERT. No longer is there a 75% or a smaller 50%, in some cases, goal of certified EHR use. And all those participants must also make a promoting interoperability submission. Now, there's one big, if understated, exception. Providers who have a temporary or permanent exception to the CEHRT requirement get the same exception for participation in MSSP. Small practices, non-patient facing practices, hospital-based or ambulatory surgical center-based practices have a pass in MIPS for promoting operability. They do as well in MSSPs. Although, warning, that's contradicted somewhat by the rule that, or the intention to head to solely ECQMs in the near future. So it may be an empty promise of Medicare to accept those from the rules. Now, an interesting side note on this promoting interoperability requirement pertains to facility-based providers. Medicare offers an exception to promoting interoperability requirements for providers who are facility-based and therefore have no control over the EHR in use at the facility. This is important. Those providers didn't and can't have a say in which EHR is used, but they also don't have any power to insist on data being delivered to them. And I think that's what, in practical experience, what we find limits use of those. But the only automatic grants of the exception occurs for hospital-based and ambulatory surgical center-based providers. And for them, it only applies automatically if one of the facilities in which they work accounts for at least 75% of their billing volume. Providers in other facilities like skilled care and other long-term care facilities, or providers who serve multiple facilities with no one of them rising to at least 75% of their volume, don't automatically get that exception. Those providers must make an EUC application. That is an exceptional and unusual circumstances application to be granted the exception. Of course, that EUC application needs to be repeated each year if it still applies. And I'm finding in our clients that make that application that it's ratified, it's verified fairly quickly by Medicare. But again, don't expect it to be automatic if you're not in one of those specific facilities or have at least 75% of your volume in one. Another important change in the rules is a prepaid shared savings option. Now, you may remember in 2024, Medicare introduced an advanced investment program called the AIP that is available for new low revenue MSSP ACOs. The program seems to be popular, it seems to be successful, and for 2025, Medicare finalized a rule to make advance payments of anticipated shared savings available to select renewing ACOs. Now, there's a number of qualifying prerequisites regarding prior year performance, but it may be a very useful tool. It's only available at the time of renewal, but early renewal is permitted to qualify for this option. If the first year of a new renewal is 2025, you're eligible for this in 2026 without an early renewal. Now, as for the advanced investment program, a couple of refinements. Voluntary termination with payback has become acceptable without leaving the MSSP. That was an unintended consequence of the rules as written last year, and that's been corrected. And they've also clarified that if Medicare involuntarily terminates an ACO's participation, that payback of any AIP funds is required. And payback in either case is expected within 90 days of the event. Now, a few adjustments to financial methodology for MSSP ACOs, a number of refinements. There's a mechanism to remove from benchmarks and performance year calculations service codes that exhibit, by analysis, significant, anomalous, and highly suspect, that's abbreviated SAHS billing activity. So they will tend to remove those codes both from the benchmark years codes and the billing years codes to just eliminate those from the shared savings or shared loss calculations. They've also provided some clarity on methodology for capping the ACO's risk score growth and regional risk score growth. They've provided some more clarity around the health equity benchmark adjustment, and they've clarified and refined the rules for reopening payment determinations under various circumstances. Now, there's also some changes about the expectation to have 5,000 beneficiaries. In the past, if an ACO dropped below 5,000 beneficiaries, they were put on in a provisional status, required to develop a cap that is a corrective action plan. But what they've found is that most of these do correct, that they've instituted a sliding scale for minimum savings rates, that's MSR, and minimal loss rates, that's MLR, and that's been effective to prevent anomalous losses or gains, so they're not taking the drop below 5,000 as seriously as they did. Current rules now say that you have to have 5,000 beneficiaries at the start of your ACO or at renewal time, but interim drops no longer require an automatic corrective action plan. Now, they typically tweak assignment methodology in most final rules. This year's no exception, with a couple of interesting tweaks. First, they're making an exception to voluntary assignment for patients who are eligible for a disease and condition-specific APM model under study by the Center for Medicare and Medicaid Innovation. They point out that voluntary assignment is a rare event. Out of 10 million Medicare beneficiaries in the MSSP program, only 83,000 of them in the last measured year voluntarily assigned, and they think it's important to fully study these disease and condition-specific APM models to put those to allow those patients to be attributed to those models so they can be fully studied. The other change to the assignment methodology relates to the step-related assignment methods. The step 1 is based on primary care services by primary care providers. Step 2 is based on primary care services by second-tier specialists, which can serve in a primary care capacity. And step 3 is the new step. It involves a 2-year look back for someone who was seen by a primary care physician 2 years ago, and again by non-physician primary care provider in the current year. So this should result in more patients being attributed to each ACO. Now, and amongst the smaller things happening, there's been relaxation of antitrust concerns based on withdrawal by the Department of Justice and the Federal Trade Commission of some of their outdated policies on antitrust. So there's not going to be an automatic review anymore of ACO applications. They will handle those on case-by-case basis if there's any special reason for concern. And they've also relaxed some beneficiary notification requirements. And that, I think, is just about it for the MSSP related rules, or at least the high-level rules, and a brief review of those. We will dive into some of those in greater detail in future days and weeks. And of course, if there's something you want us to dive more deeply into, please just let us know what that is. So moving on, let's talk about alternative payment models. MSSP is just one alternative payment model. It was broken out by Medicare as a permanent project group in Medicare. Most other APMs run by the Center for Medicaid and Medicare Innovation are used to test techniques that they might add to the MSSP. So they are now different topics within Medicare. Now, first, about quality measurement, and I'll reiterate what I've said in the section about MSSP. Any MIPS APM can elect to use the APP or the APP Plus measure set to generate a quality submission for their MIPS eligible providers. It's unavailable to traditional MIPS participants. Only the MSSP must use the APP Plus measure set. Any other APM can use either of them or neither of them. So be aware that it is there. Now, the new complex organization adjustment they've implemented for MSSPs, which typically have multiple independent tax ID numbers, multiple EMR types. For APMs that also any APM, whether you have multiple organizations, multiple EHRs or not, would appear. You also get 1 point for every ECQM submitted with the same limitations I've described elsewhere. That 1 point can't drive you above a perfect score either for the individual measure or the composite score. Changes in promoting interoperability, the same ones that apply to MSSP. There are actually no new rules about APMs in the 2025 final rule, but one of the most consequential rule changes was finalized in the 2024 final rule that goes into effect in 2025. Starting then, all participants in APMs, regardless of QP status, must be on certified EHR technology and must make a promoting interoperability submission. There is one big, if understated, exception. Providers have a temporary or permanent exception to CHRT requirement, get the same exception for participation in an APM. They don't need to use CERT. They don't need to make a promoting interoperability submission. That is, includes small practices, non-patient facing, physician, hospital-based, or ambulatory surgical center-based providers. An interesting side note on this promoting interoperability requirement pertains to facility-based providers. Medicare offers an exception to promoting interoperability requirements for those providers who are facility-based and therefore have no control over the EHR and use at the facility. But the only automatic grants of that exception occurs for hospital-based and ambulatory surgical center-based providers. And for them, it only applies if at least 75% of their volume comes from a single facility. Providers in other facilities like skilled care and other long-term care facilities, or providers who serve multiple facilities with no one of them rising to 75% of their volume, must make an EUC application to be granted the exception. Now, and of course, that EUCA application has to be repeated each year that it still applies. And in our experience with our clients who've made these applications, it's granted quickly and almost automatically or what appears to be automatically by Medicare, but it won't happen without your application. Now, additionally, it applies to all APMs, including the MSSP. There's been an update to QP, that is qualified participant and partially qualified participant thresholds for 2025 and beyond. This has been delayed for a few years because of COVID, but they're finally progressing to the previously scheduled advancement of these thresholds. If you're in a Medicare option APM, QP threshold is at 75% of your payments come through that the MSP or the APM, or 50% of your patients. Partial QP, the threshold for payments goes up to 50% from 35, and the threshold on patients is 35%. I expect there's likely be fewer QPs, perhaps the same number of partial QPs. And in the all-payer option, the QP threshold goes to, based on payments, goes to 25% of your Medicare, 75% overall, and based on patients is 20% of your Medicare patients, 50% overall to hit QP status. Partial QP, 20% Medicare, 50% overall by payment, or 10% to 35% overall on patients. So again, whether it's Medicare option or all-payer option, those thresholds become a QP or partial QP toggle up rather significantly for the 2025 year. Now, the APM, the advanced APM incentive payment, has been changing with a few, as previously scheduled, with a few alterations to that. From the inception in 2017 through 2024 performance years, the incentive was a 5% lump sum payment paid 2 years after the performance year in which a provider became a QP. And the last payment year of that 5% lump sum is 2024. So everyone should have already received their last 5% lump sum payment. For the 2023 performance year to be paid in 2025, there's a 3.5% lump sum payment. So expect that next year for your work last year. And for this current 2024 year to be paid in 2026, Medicare added, or the legislature added in March of this year, March of 2024, a 1.88% lump sum payment to coincide with the new method of that ongoing new method of incentivizing QP participation. That is a higher conversion factor on the physician fee schedule. Now, there's already a 2.5%, or excuse me, a 0.25% automatic increase in the conversion factor every year for the rank and file Medicare participant, participating physician, that is. That goes up to 0.75%. That is 3 times that standard upgrade, 0.75% for QPs. So expect that to start and continue indefinitely. You're qualifying for that in the 2024 year. It'll be paid in 2026. it'll apply to each of your Medicare payments for service that's delivered in 2026 and beyond. That pretty much exhausts the important points for alternative payment models. Let's move on to MIPS. An interesting year and somewhat consequential, but a smaller set of changes than for the MSSP. The important numbers, of course, we're all interested in what's happening to the performance threshold. That's the the total composite score across all four MIPS categories. That switches a provider from the negative adjustment when you're below that threshold to a positive adjustment above. That's remaining at 75%, and it's scheduled to stay there at least through the 2027 performance year. Now, the data completeness threshold is another thing that we all watch carefully. That data completeness threshold remains at 75% through at least the 2028 performance year. And of course, that 75% data completeness threshold applies to all Medicare quality reporting, whether it's the Part B claims method, the MIPS CQM method, the Medicare CQM method, the eCQM method, to MSSPs, to APMs, anyone who's making a quality submission, it has to include 75% of the expected denominator patients. Now, the MIPS CQM measure inventory, of course, they tweak this every year. The inventory for 2025 is 195 measures, 3 of which are only usable in MVPs, and I won't go into the details of what's been changed. I think there's 60 or 66 measures with substantial modifications. Again, my advice for everyone is don't assume that the measures you used last year are still available or are still specified with the same specifications. Be sure you review the availability and specifications for the measures you expect to use in 2025. Now, there's new minimum criteria that have been finalized for considering a submission, a qualifying submission, to be scored and to effect. Now, this is a really important rule, and I think it's a great thing that Medicare's done to change this. What's been happening in the past is people who get an exception, either for one of the performance categories or for all, those exceptions are nullified if a submission is made. So if you have an exception for promoting interoperability, but you make a promoting interoperability submission, it erases the exception and you get the score that you submitted. Now, in a lot of occasions, it seems that there are automated systems or errors that make an empty submission for providers. So you get a quality submission with the TIN and MPI attached, the tax ID number and the Medicare provider number, the NPI, and they're empty. They don't declare a measure. They don't declare a numerator or denominator. They don't give the scores for the improvement activities or don't attest to improvement activities. They don't give any of the numbers or attestations for promoting interoperability, but the existence of those submissions have nullified exceptions. So now they're saying that they're not going to count a submission unless a quality submission has to have at least one measure with a numerator and a denominator. If there isn't that minimum standard, it's not counted. It won't erase your EUC exception. For improvement activities, you have to have at least one improvement activity declared and a yes attestation for it. If you don't have at least that, it won't count. It won't erase your exception. And promoting interoperability, this is actually pretty aggressive. It has to be a complete submission for all of the required elements. So it really has to be a fairly detailed and complete submission to count and to erase your exception. So good thing, goes into effect for 2025. Now, they've also clarified policies for multiple submissions. It's pretty much what they've been doing already, but made sure it was codified correctly. When there's duplicative submissions, by the same mechanism and the same source. So if a qualified registry makes a submission and then makes another one for you, the most recent is the one that's used. Those repeat submissions, the more recent one nullifies the one prior. Now, when it's a different mechanism or a different source, that is, you get a qualified registry, you get a MIPS CQM submission from two different registries, or you've made one yourself and the registry's made one, they're both accepted, they're both scored, and you get the benefit of the highest score. Now, additionally, there's a big change in the cost category for traditional MIPS and for MVPs. There's a change in alignment of the scoring range to match the to match the performance threshold and the spread of scores in traditional MIPS. So from now on, starting with the 2025 performance year, the median score for cost is going to be given a score that corresponds to the performance threshold for the overall MIPS program. And then the deviations above and below by standard deviation will be mathematically divided to use the full 0 to 10 scale. What this means is in up until now, the cost has been an average cost score brings down your overall MIP score to something in the negative adjustment range. This means that it will, if you're have a better than average cost, it's going to bring your score up. If you have a lower than average cost, it's going to bring your score down, which is far more appropriate. So this is a great change. It's going to significantly improve scoring for the average practice and above. I also should decrease the negative consequence even for those who are below the average. There are 6 new episode cost measures. There's no changes to promoting interoperability of note. The usual changes in improvement activities are moving for, modifying to, adding to, but the important thing about improvement activities is they've eliminated the weighting. There were medium weight and high weight activities. That's no longer the case. Every improvement activity has the same weight. For traditional MIPS, you must submit 2 improvement activities to get a full score. For special categories, that is rural, small practices, other exceptions to that, only 1 is required to get a perfect score, and MVPs only require 1, not the 2 that's required by traditional MIPS. Now, they seem to change the topped-out measure strategy every year, and this is no exception, with an interesting and fairly big change. For a handful of specifically designated topped-out measures that are critical for specialties without an adequate measure set to choose from, they've ended the special scoring that puts the top score at 7. They'll use the entire 0 to 10 scale for submissions that they receive, and they intend to publish every year that list of measures that qualifies for the full scoring instead of the top score of 7. This is a good call for those specialists without adequate measures. I mentioned a complex organization adjustment in other sections of this discussion. In Traditional MIPS, that complex organization adjustment, applies to virtual groups, who by definition are separate TINs collaborating on a single traditional MIPS submission. They may have multiple EHRs, so they get that complex organization adjustment if they're using ECQMs, just like MIPS groups and APMs. They get one quality point for each ECQM. It cannot exceed 10 points. It cannot per measure. It cannot exceed a perfect score composite for the quality component. Now, there's also a new EUC offering. So for submitters, and I think this is a great change as well, for submitters whose third party did not make a submission for them, with some exceptions, some clarifications, some requirements, you can apply for an EUC, and this is the only EUC that you can apply for after the submission period is over. So EUC applications are accepted anywhere up until November 1 following the submission season. So if for unavoidable issues, your third-party vendor did not make a submission for one or more of the submission categories, you can get a pass in retrospect if that application is made before November 1st, after the submission period ends. So finally, let's talk about MIPS value pathways and the new rules regarding these. Now, there are 6 new MVPs announced in this final rule. I won't go into the details here. They've combined 2 neurological MVPs into a single one. There's now 21 total MVPs available. Medicare estimates that 80% of providers now have an applicable MVP. They each require one improvement activity. Weights no longer apply to anything. There's no longer medium weight or high weight activities. They're all of one weight, and you need to do one in an MVP. You no longer need to choose a population health measure. There are 2 population health measures. MVP submitters had to choose one. Now they'll be scored on both of them, and the best score applied. If neither can be scored, it gets factored out of your submission. Now, it's measured against the parent group. I imagine this is to be sure we more often get a submission that has a data completeness, more the minimum number of patients. Now, they're also aligning cost scoring with a new traditional MIPS policy. Cost is now they're now coordinating the cost scoring scale with the performance threshold. So they're setting the median cost score for any cost submission. Any cost measure, not a submission, cost measures aren't submitted. For any cost measure that applies, your cost score, the median score is set at the performance threshold of the MIPS program, and then variation above and below that mean get divided into the typical 1 through 10 or percentile-like categorization. Cost measures like the pop health measures will be calculated at the parent group level, and again, I think this is a method to more often get minimum number of points in the denominator. The value in primary care MVP, which has had some modifications, and it's linked to a new payment method called the Advanced Primary Care Management Service. And they're considering a similar ambulatory care model for specialists in the ambulatory setting. So watch for more information on that, both the primary care, advanced primary care management program, and if they finalize a ambulatory care model for specialists in coming years. Now, perhaps the most important thing about MVPs for 2025 is what is not in the final rule. 2025 is penciled in as the year to make subgroups mandatory for submission of MVPs, but it looks like MVPs can still be used to score all providers in multi-specialty groups of any size and any specialty composition. So they've not yet moved on to that next step in the evolution to mandatory subgroup submissions, and made no indication whether it'll happen next year or when they're proposing to make that happen. And in fact, the only statement they made about the future is that they haven't determined yet when they'll sunset traditional MIPS and go to full-time MVPs. So that's you still have some years to get used to them, to test them, and a solid strategy for preparing for MVP submission is to do both an MVP and a traditional MIPS submission side by side and take the best score to set your MIPS adjustment. Well, after a long and exhausting discussion, I think that pretty much hits all the high points in the final rule. And again, we'll tackle some, get into more details in days and weeks to come, both what's considered important by our Mingle subject matter experts and what you submit as questions and requests for more clarity. I want to be helpful. I want this to be useful to you. Don't hesitate to correct or supplement my answers, share your experience, ask your questions. We can be smarter together.